All right. Good evening, everyone. Welcome to the Grand Rounds. Before introducing our speaker for tonight, let me share the slide sets that will allow you to have your CME and MOCs credits. So you'll have this Grand Rounds presentation recorded and situated on the YouTube websites, where you'll be able to go back and check in to get your CME credits. For getting the CME credits for now, you can text at the number 888-816-4890, 25680. Please text to the number, and it should be as an SMS message. And if you would like to also get an MOC credit, then please complete the step 1, and the link which will be displayed back again would have a room code future 2025 to answer the quiz. And if you're able to successfully answer the quiz, you'll have your ABIM credited with the MOCs. So against the scan QR code is here. You can use it to complete the steps, or you can go back and visit at the next within the next 12 hours to get your CME or MOC credits. Again, the link will be displayed back again. With that, I'm really pleased and honored to bring in for the presentation to introduce Dr. Paul Saraja. Paul, welcome. And Paul has had a distinguished career, and a lot of people would not know that he's actually my mentor too. When I trained, we had a mentorship link, Paul. You have to be.
We do. Okay, we do.
I need to admit that. Everybody has a mentoring moment, and age is no bar. Like, you can be mentored from any person at any age. Well, I came back and retrained in this country, and when I was in Mayo Clinic, Paul was just becoming a faculty, and we were together in one of the rotations. But I had this privilege to see his career evolve in front of my eyes on how a fellow in training evolves into a young faculty role. And his immaculate presentation, Paul, I still remember your training with Rick Nishimura in the hypertrophic cardiomyopathy, and you presented a Grand Rounds in cardiology on HCM. At that time, you were devoting a lot of your time in structural component of HCM or risk stratification and other things, and I really enjoyed that. But that was the beginning of a career which has basically become a spectacular one, and Paul is celebrated as a pioneer, and he's working at Minneapolis Heart Institute as a Roger L. Lynn Hardick Chair of the Valve Science Center since 2016, so it's been almost over 9+ years. He's also the director of the Center for the Valve and Structural Heart Disease, and he works as a staff cardiologist at the Minneapolis Heart Institute at Abbott Northwestern Hospital. His education, as I mentioned, was at Mayo Clinic, where he rose to stardom as a professor. He was also the program director of the Interventional Cardiology Fellowship, and he has had an extensive training in leadership roles, and subsequent to his tenure at Mayo Clinic and now at Minneapolis Heart Center, he's celebrated in multiple societies across the country and world. He's affiliated as not only as a clinical trial leader, but also in many foundational roles in several committees worldwide. What was very striking when I looked at his CV was his role in innovation. I did not know, Paul, that you have 20+ innovation as patents, and that's amazing. And over 200 manuscripts, 50 book chapters, and perhaps mentored so many people and colleagues. And today we're going to get a first-hand glimpse of his role in structural heart interventions, particularly with his focus on tricuspid valve therapies. With that, Paul, we are really delighted you accepted this online invitation. Maybe perhaps in the near future, we'll bring you in here and have a Grand Rounds in person. Thank you very much for joining us. The floor is yours.
Well, thank you so much, Partha. That's an incredibly kind and humbling introduction. It's hard to believe we go back decades, isn't it? It's hard to believe. So it's an incredible honor, and I just want to thank you for the opportunity to be here with you all. And it's always humbling when people want to take time out of their evening to come listen to a talk, and I'm just really grateful for the opportunity. So I'll share my slides and get going, but love to talk more about what we're going to cover in this presentation, but anything that anybody wants to talk about career-wise or topic-wise, what have you, I'm here for you. So thank you. So I'm going to share my slides. Hopefully they'll come across okay. But today's focus for this grand rounds is on transcatheter tricuspid therapy. And so here are my disclosures. I do have a number of conflicts that are important to note, importantly, my roles in several clinical trials in this space, especially TTVR with Vista, as well as a TriClip with Triluminate, and then other consulting roles with various startups as well. So I'm going to start with, well, why should we be interested in transcatheter tricuspid therapy? You know, why is there just really just a lot of interest in this space that has come about recently? And, you know, when we look back at TR, this is a space that has historically been described as the neglected valve. And there are many reasons for that neglect. You know, first, it's a relatively less common valvular lesion, and thus it's relatively less studied in terms of lower prevalence. It also has, interestingly, a pretty long indolent period. You know, even severe TR patients can live for a long time. They get treated with Lasix for other reasons, and they can hover under the radar for a long time. TR historically has also been undercoded in terms of severity because a lot of us can be guilty of calibrating what we see in terms of color flow to the left side of the heart. But we all know that color flow on the right side is much less because the pressures are a lot less. So the severity can be easily underestimated. And then the other reason, and certainly these are not all of the reasons that are out there, but I'd like to volunteer that one of the reasons why this space has also been neglected is because historically we have looked at ventricular response to valve disease as an indicator for therapy. But when it comes to TR, the RV is often the last to go. It's actually the atria that dilate first. So when we're looking at the RV and trying to get an idea as to whether or not to treat a patient, it's often too late by the time the RV is enlarged. And so when we think about these different aspects, I think it helps us to understand, well, not only is there are multiple reasons why TR is neglected, but we have a current understanding that is limited in terms of when to time things and when to treat things. And percutaneous therapy, I think, will help address many of these issues. And that's why I always start with this slide, because these reasons for neglect are also the reasons for interest. And they're an important context in terms of how we should think about TR. Now, this area of neglect is important to note because these patients, I believe, and many others as well, that TR will only become more common. You know, we know that it's an age-related disease like many other valve lesions. You know, this is a graph of left-sided disease as well as moderate or severe TR. We know that it's age-dependent. We know our population's aging. But one thing that's also interesting when we look at the prevalence of TR is that I believe this will also increase because we are getting so much better at left-sided therapy. So in other words, if we look at survivorship of cardiovascular disease of the left side, whether it's saving lives with primary PCI or treatment of MIs, or saving lives with more TAVRs or mitral therapy, what we're doing is we're creating a scenario where patients with AFib and heart failure with preserved ejection fraction will tend to be more common. And AFib and HFpEF are really the instigators of TR. And so to give you an example of that, this is data from our center here where we looked at 1,800 plus patients who had no TR at left-sided surgery. So in other words, aortic or mitral therapy. And then we looked at the prevalence of TR among those patients. And what happened is that 1 in 7 patients developed TR within 5 years. So 1 in 7. It's really quite remarkable. And so the prevalence of TR is going to grow with more chronic heart failure. And that's a good problem because that means we're allowing patients to live longer. Now, we also know that when it comes to tricuspid valve surgery, which is the gold standard, that this surgery can be challenging because these patients can have RV issues that make perioperative recovery somewhat challenging. And we know from these data from Chen et al., where they looked at 6,500 tricuspid surgeries and they excluded the acute situations, they excluded patients with endocarditis, and they focused on just TR, that the operative mortality in these patients was over 7%. So already a high risk situation. And what's interesting is that these patients had a median age of 65 years. And if we keep that in mind, we'll compare that to what the median age for the transcatheter patients are, which is a lot higher. So that's a lot about the why. So we know that these patients are common, they're going to become more common, and their options are limited because often surgery is high risk. So this is a ripe area for transcatheter innovations. And when we look at what's possible out there, there are so many different technologies. We have so many repair, replacement technologies. And among replacement technologies, we have heterotopic and orthotopic approaches, many different things. And this is a very small sample of the technologies that are out there. And so I'm going to talk a little bit about each of those technologies. But what we know that from these technologies is that the feasibility of everything that we have in front of us for simple repairs or complex repairs or total valve replacements have all been demonstrated with transcatheter approaches. And so the feasibility is already there, and it's a matter of establishing more evidence as to how and when to treat these patients. Just go for here. So I'm going to first start with transcatheter tricuspid valve repair. And the prototypical device for tricuspid repair is the TriClip system. This is a system that has been in place for a number of years already. We actually did the first one in the world in 2017. And since then, there have been thousands and thousands of patients treated with this technology. It's the predominant technology by far. And the TriClip system, for those of you who may or may not know, it is similar to the MitraClip, except that it has a number of steering and design enhancements to work in the right atrium, which functions at a lower height relative to the AV valve in comparison to the mitral valve. It has similar devices, NT, NTW, XT, and XCW. And the pivotal trial that established this therapy in the United States is TRILUMINATE. So on the right-hand side, all the patients who are in TRILUMINATE had to have suitable anatomy for the technology. They had to have adequate medical management, and they had to have no pulmonary hypertension. And I put in there that these are all assessed by right heart cath because a right heart cath was mandated to be enrolled in TRILUMINATE. The right heart cath had to confirm that GDMT is optimized as shown by wedge pressures that were controlled, so anything less than 20. And it also had to verify that there was no severe pulmonary hypertension. So that's a very important thing to keep in mind, is that the left-sided disease and pulmonary hypertension were all completely removed from TRILUMINATE in order to focus on TR alone. And that's a very unique aspect of TRILUMINATE. So in TRILUMINATE, we took these patients and we made a decision. A good portion of them went into the pivotal arm based on the ability where we thought we'd be able to get to moderate or less. And then the other patients went into the single arm where we felt that there would be TR reduction, but we weren't sure it would get to moderate or less. And the patients in the randomized arm were randomized against GDMT alone. So here's what we saw in TRILUMINATE. And we saw that for both the randomized arm and the single arm, that TR reduction was highly significant for both. In fact, it was almost 90% got to moderate or less in the randomized arm. And in the single arm, please keep in mind what I just mentioned about these patients were not expected to get to moderate or less. Actually, 4 out of every 5 ended up getting to moderate or less. So the device actually exceeded our expectations 4 out of 5 times. And in both arms of the study, the TR was significantly improved. And these patients also were relatively complex. The majority of these patients had the most severe TR there was, the grade 5 or torrential, and leads were very common. So up to a third of the patients in TRILUMINATE actually had leads in place when they were getting treated. Some examples of patients who were actually treated in TRILUMINATE to illustrate as a patient of mine on the far left-hand side. This is a patient who had 2 devices put in with a very mobile lead, as one can see there, and with an excellent result in terms of mild TR. And then in the middle, this is what I like to refer to as a starburst of coaptation planes. If you look at this transgastric view, you can see that the coaptation planes form in the shape of a star. These are some of the most complex ones to repair because the coaptation planes are quite variable. But here on the right-hand side, this is a beautiful result with mild TR. And this is also in a patient with a horizontal heart. So this patient had a starburst coaptation plane plus a horizontal heart and got mild TR. And what was really amazing is that these types of patients with some of this complex anatomy were among the earliest experience, because when we look at that TR reduction, it's remarkable not only for how much TR was reduced, but also because the median number of cases per site in TRILUMINATE was only 4. So it was actually a very early experience for most operators in terms of getting tricuspid therapy done. And this is important too because the safety profile was well demonstrated. When we look at the pivotal arm and the single arm data, remember the single arm are the patients who are more complex. And then we also look at the B-Right study, which is on the far right-hand side. B-Right is the post-market European data. And we can see in all of these arms, the major adverse events were very low. They're all in single digits. Most of them are actually 0. Pacemaker rates were essentially close to 0, as we can see here, which is very important for a right-sided intervention. Single leaflet device attachment was probably the most notable AE, and we see that that was around 7% for TRILUMINATE. In the post-market study, it had dropped to 3.8%, and so it's improving, but it's an important area that needs to be worked on more. Now, the other thing that was noted with TRILUMINATE, and this was honestly a little bit of a disappointment for a lot of us who are working hard on this trial, was that there was no survival benefit for TriClip. And this went counter to what a lot of people's impressions were in terms of how TR would affect people's lives and how correction of TR should improve survival. But I'm going to show you a few things as to why there was no survival improvement. So first, when we look at the 2 arms of the study in TRILUMINATE, the survival was actually 90% for both arms. And that's important, but at the context of this is that these patients had only TR. So the mean left-sided pressure for pulmonary capillary wedge pressure was only 15. So it was normal in terms of being a mean value. So even though a lot of these patients had left-sided disease and a lot of these patients had reduced EF, they were extremely well managed from a GDMT standpoint. And what that tells us is that TR, even when it's severe, when it's well managed, these patients can actually do relatively well. And here we see in the control arm, so please keep in mind that in the controls in TRILUMINATE, please remember that more than half of these patients had torrential TR. They had some of the worst TR that we grade on echocardiography. But despite that, their cardiovascular mortality rate was less than 5%. So again, this goes towards the notion that patients with TR who are well managed can actually do okay, at least for the first year. Longer than that, we still have a wait and see, but the survival was far better than we thought it would be. And when I say far better than what we thought it can be, it's because there's a certain context that needs to be thought of when we look at what was being known, what was known at the time TRILUMINATE was planned. So here in orange are all the studies that were available when TRILUMINATE was being planned. And here, these are natural history studies of TR. And what was interesting about these studies is that these are studies with TR that was associated with other disease. So in other words, left-sided disease. And from medical school or whatever medical education you may have had, a lot of us would know that when it comes to prognosis, there's nothing worse than biventricular failure. So TR with untreated left-sided disease is biventricular failure. And so not surprisingly, these patients would have 1-year survival rates of, 1-year mortality rates of 20 to 50%. Now, if we look here in blue, on the other hand, and these are in blue here are all studies that popped up when Triluminate was being enrolled. And in gold there, you can see Triluminate pivotal. And what's interesting about these blue studies is that these are studies where TR was isolated. So TR isolated from left-sided disease. And here the 1-year mortality rate is all around 10%. It's all in that ballpark of what we saw in Triluminate pivotal, but this was all just recent. So there's a very big difference when we take TR in the context of other disease versus when we take TR completely by itself. The survival of TR is actually not too significantly impaired for just that first-year follow. Now, even though there wasn't an improvement in survival, we know from Triluminate that there was a significant quality of life benefit, and this is a large in magnitude. It far exceeded what we commonly refer to as the minimal clinically important difference, MCID, of 5 points. It's around 15 points, and it was the same for the single arm as well as the randomized arm. And here, because of the magnitude of benefit and the absence of waning, there was no evidence of waning. Most of us feel that this was not a placebo effect. There certainly always is some placebo contribution, but the magnitude and duration of this and the absence of waning goes against that. And what also goes against that is several other things. So first, in terms of the magnitude, the number needed to treat, whether we look at greater than 10 points or greater than 20 points or being alive and well, it was a very low number needed to treat for benefit. So that's helpful. And then when we talked about it in terms of the safety, effectiveness, and the benefit risk profile, these are some of the comments that were made. It was overwhelming at the FDA panel in terms of what we felt was safe as well as effective. And there are also comments about the placebo, certainly acknowledging that it's unblinded, but that a sham procedure would not have made a difference in this trial's results. And so certainly anytime we have an open label device trial, this is going to be somewhat controversial, but there's a lot of supportive data that led to the Triluminate being approved. And I'm going to cover a little bit more of that later on in the presentation. So another repair device that's available is Pascal. And so this is has very similar results to TriClip and what we saw in Triluminate. This is at a very important trial that's ongoing right now, the CLASP TR study. It's a large trial, over 800 patients. It's also felt to be very safe in terms of the safety profile, similar to TriClip in terms of what we saw for TR. And in terms of the efficacy, it certainly is in the ballpark in terms of TR reduction. And hopefully this trial and the results will be available to us very soon. Now, when we know or see these patients with TR, we know that there are simply some patients who cannot be repaired. And this is an example of one of those patients. So this is a patient whose gaps are very large. And when we think about trying to restore or recreate the coaptation here, we can see that it would essentially be impossible to try to get this repaired with a TR device. A ring might work, but a TR device here in terms of the physical limits would simply be out of bounds. So with that, we have a clear role for transcatheter tricuspid valve replacement. And this is a very important technology where hundreds of patients have already been treated with TTBR. And there are many different technologies that are out there already. Evoke is certainly the market leader, but other ones are also coming online. And these are relatively large bore devices, but they can be treated very safely in our patients. And this is an example of an Intrepid case where we did. Here you can see top left here, this is actually a starburst coaptation planes again. The valve is placed with leaf of TR. And this is actually a 42 French system that was simply closed with a figure-of-8 stitch. So obviously, this is coming down in size with the new 29 French systems, but certainly shows what's possible in terms of the treatment. An important point is that we know that the risk profile for this technology is evolving, but this technology, to give an idea of the demand, is that we've had TMVR in the United States for 10 years as of next month. We did the first 10-9 in April of 2015. So we've had 10 years of TMVR in the United States. But in terms of TTVR, we've only had it for a few years, and we already have a device approval. So the demand for TTVR is far outpacing what we've seen for TMVR in terms of success for enrollment. And we already have approved devices, which is really quite remarkable. And clearly, the market leader is the Evoke system. It comes in 3 sizes. It's a 28 French bovine valve, and in Trisend 2, these are patients who had severe symptomatic TR, and they were randomized between Evoke plus OMT versus OMT alone. And the plan is for an annual follow-up. And this is a 2-to-1 randomization that we saw for Evoke. And as we would expect for replacement technology, there was essentially elimination of TR with TTVR using the Evoke system. We can see here that 95% of them got to mild or less. And then that degree of TR reduction remained sustained out to 1 year. In comparison to the controls continue to have severe TR or worse for the 1 year follow-up. Now, one of the things that is important to note is that the adverse event rates are higher with replacement technologies. And what we saw in Evoke was that the MAE rate at 30 days was 27%. This is higher than what we saw with TriClip, which was 1.7%. But the MAE rate was acceptable for TTVR because it was compared to the surgical standard in terms of Medicare claims. This is an objective performance criteria with a bound that you can see that was used at 37%. And with that, the safety profile was felt to be favorable. That plus the TR reduction and improvement in quality of life was what led to the device approval. And so here you can see that the mean change in KCCQ that we saw with Evoke for the first 150 patients here was around 15 to 17 points. And that is pretty much what we typically see for TR therapy. Often, whether it's TriClip or whether it's Evoke, it's generally in that 15 to 20 point range, which is highly significant for KCCQ improvement. And this device was approved last year. Now, an important thing to keep in mind is that when it comes to the tricuspid valve, this valve is much larger than we see for the mitral valve. And so as we look at how we need to treat these patients, it's not simply that we can just take a mitral valve and turn it into a tricuspid valve. It actually is that we need special designs to address that very large anatomy. And as I mentioned earlier, these TTVR technologies come in 2 flavors. There is either the orthotopic approach or the heterotopic approach. Orthotopic obviously meaning implanting at the annulus, whereas heterotopic means implanting in the cava. And so one example of an orthotopic approach is the V-Dyne. This is a technology that is born here in Minnesota. What I really like about this technology is that the outer frame is shaped like a right ventricle. And so you can see that there's a circular valve in the middle, but the outer frame is very gentle. It actually has a side deployment to minimize the profile, like slipping on a shoe. In that outer frame, by being shaped like a right ventricle, it's very gentle on the RV function, which is obviously very important for these patients with TR. In terms of the heterotopic technologies, there are several of these like Cree valve, which is an SVC anchor, followed by a dedicated valve that can be positioned across the annulus. This is an example of a Cree valve that has been put in. And then there are valves like Tric valves and Trillium, which can have incredible promise because they are very effective at relieving right-sided congestion. And paradoxically, even though they're not at the level of the valve, these heterotopic technologies have been associated with RV remodeling, which has been favorable. So still a lot that we still don't understand in that space. as an example of how the RV can be reshaped with these TTVRs. This is that V-dyne valve. Again, this is that 28 French system with 30 millimeter valve. And look at how asymmetric the outer frame is and how it fits the RV here. And this is an example of a 3D print of a patient before and after. And you can see how that kidney bean shape is preserved and actually becomes smaller after the V-dyne has gone in. And this technology is in an EFS study right now, and it's a very exciting approach to treat them. So in the last little bit, I'm going to close by talking about what we should expect from this field. And I think this is where I think it could get somewhat exciting in terms of what we have to look forward to. So when it comes to percutaneous technologies, I think these things have really blazed new clinical pathways because we're looking at an area that's been neglected for a long time and talking about it in ways that we really didn't learn about back in medical school days. And so on the left-hand side, many thanks to Becky Hahn and the ECHO groups and talking about how to quantitate TR in different ways. You know, we have mild, moderate, severe, and now we have massive and torrential. And it's not about just looking at the color flow anymore. It's actually getting to the bread and butter of real quantitation in terms of how we're affecting patients. And because we're quantitating the TR, we're also understanding the effects of what we do in a much better way. In addition to measuring, we're also describing the valve in a better way. So on the right-hand side, we have inflow views, we have sweep views, we have transgastric views. MPR is essential for doing these procedures in terms of steering because the tricuspid valve is highly variable in its position and orientation, as well as coaptation planes. And so talking about these valves in these ways, it's a whole new lexicon that has really just opened up a whole new pathway in terms of how we practice medicine. And when we look at these patients, you know, it's like the field of dreams approach. Once we have a technology that can be helpful, these patients start appearing out of the woodwork. And it's very similar to what we saw with TAVR, as well as what we've seen with MitraClip. These patients are actually out there, but they're not going to come unless we have a technology that can help them. And once we do, they just start filling up our clinic. And that extreme pathology is out there. So this is an example. This is a patient who walked in to my clinic, got a T, and then saw me the next day. And it's amazing. I don't know where her tricuspid valve is, but I'll tell you, she's asymptomatic. And it's just remarkable. She's 80, asymptomatic, and we actually had a lot of discussion about whether they should do anything because if the main benefit is quality of life, is it worth the risk? But these patients, it's actually much more common than I think we would rather admit. Another thing to look forward to in terms of how we treat our patients with TR is that I think we'll continue to get better in terms of repair success. And so when we think about repair versus replacement, which is a debate that appears at every valve meeting, the repair success is actually a moving target. So here on the left-hand side, what I've done for you is I've taken every report of TriClip with core lab data, and I've laid it out in a chronological order, going from left to right. And what you can see here, if you go left to right in chronology, is that the TR reduction is getting better. Each report, the amount of green is going up. And that's because we have experience that's increasing. We have newer technologies that are helping us. We're understanding the imaging. We're being able to manage leads carefully. We're getting better at heart failure management. And our interventional echo doctors who are just amazing, they're all learning tricuspid imaging, which is making all these procedures better. So it's a moving target, and we have a lot to look forward to. We also have a lot to look forward to in terms of the way we're imaging. And so here's some really beautiful images that were taken, but these are all done with 4D ICE. They look a lot like what we see with conventional TE, and I'll have to update these images because the newest software by Philips really has just blown us out of the water. And it's really amazing to think about the possibility of doing these procedures with conscious sedation. It's already happening. I think that's a huge part of the field in terms of how we treat our patients with valve disease. Another thing that we're looking forward to is safety. And so in the earliest reports, we had some concerns about safety with TTVR. But when we look at the data, it's getting better. And we still have some more work to do here, but I do believe that it's going to happen. All the events that we have seen so far are things that we have solutions for, and there will be new technologies that will have better outcomes, and as well as the current technologies with the experience that we see. And so that safety will happen. The other thing to look forward to is more collaboration with our EP colleagues. So when Partho and I were together at Mayo many years ago, the heart team was really just coronary surgeon and coronary interventionalists. Well, TAVR came and that changed. So it was valve surgeon and valve interventionalists. And then eventually heart failure got involved because it was MitraClip and TriClip. But when we look at what really needs to happen with the heart team is actually expanding it to include our EP doctors. And when we see these patients with TR, leads are extremely common, and they're only becoming more common in terms of how we manage. And to give you an example, this is a patient who actually had a lead extraction, and this patient had a micra, and the micra actually made things worse. So the micra, we thought we were doing this patient a favor by taking out the lead to eventually do TriClip. But what happened with the micra, if we look carefully on the right-hand side here, is the micra took all the cords of the mitral valve and essentially tethered, the tricuspid valve, and essentially has tethered the tricuspid valve open. And so this patient went from being able to be treated to essentially not being able to be treated and had to get TTVR with the micra. So these are important discussions that we have to have with our EP colleagues in terms of planning it. And this is a learning issue for all of us in terms of how we manage our patients with TR who have leads. The other aspect that we're learning a lot about is what we're doing for TR in terms of how we're impacting our patients' lives. So as I mentioned before, there was been some criticism about TRILUMINATE being an open label device study, and some question about whether or not the effect is placebo or not. But I'm going to show you a few things here that help support that it's not placebo. So first, the first thing we did is we looked at the quality of life according to TR reduction. So a patient may know they got their device, and I hope they would know that, but a patient doesn't necessarily know what grade reduction they got. So they may be able to say that I had a reduction, but they probably can't tell you if they went from severe to massive or massive to moderate, etc. And what we saw in TRILUMINATE is that with core lab adjudicated data is that there was actually a very tight relation between the amount of KCCQ improvement and the improvement related to TR grade. So for every 1 grade TR reduction, it's about a 4-point improvement in KCCQ. The other thing that we also found was that if a patient had a change in KCCQ at 1 month that was 10 points, that was later associated with decrease in death, decrease in heart failure hospitalization, or the combination of the two. And so it was actually quite a remarkable association that quality of life was tied to a reduction in adverse events and follow-up. But this was not able to be shown because this trial was grossly underpowered, as I mentioned before. We just simply did not have enough events to compare the two arms to make that discrimination possible. What we clearly saw was that quality of life is associated with a decrease in heart events afterwards. The other aspect that we also saw with TriClip is that patients with end organ damage also benefit most. So if you look at liver disease or we look at kidney disease, if you look at the separation between the curves for device versus control, and it makes sense is that the sicker the patients are, the more they tend to benefit in terms of end organ damage. Again, going against the notion that this is placebo. And then the final piece of information that supports that this is a real effect is the effect on the annulus, as well as on the effect of RV remodeling and function. So this is a nice series of patients that we describe, where when we did the TriClip, it actually had an annuloplasty-like effect. So here on the right-hand side, you can see under pre, this is what the tricuspid valve looks like before. And then on post, this is what it looks like after getting devices put in by TriClip. And we can see that the septal dimension becomes smaller, and that it also becomes more saddle shaped. So it's this restoration of a saddle shape configuration for the tricuspid valve with the TriClip device. And so this is a really interesting observation that we saw in our patients. And it also went along with evidence of RV remodeling. So in another patient, this is a patient who had a cardiac MRI as part of the imaging sub-study of Triluminate. And what we saw is that before the regurgitant volume was 86, the RV volume was 237, and the diameter was over 50. But with placement of a TriClip, which is this black blooming part here, this other part that's black is a defibrillator lead, the regurgitant volume actually went down to 2 mLs. And it's hard to believe that somebody can measure only 2 mLs, but the MRI with its precision apparently can. And with that, the RV diameter also went from 237 to 166, and the RV diameter went down to 43. And so it all fits in terms of this RV modeling, because this patient was completely asymptomatic after the patient got their TriClip. And it fits with the data that Joao Cavalcante has also shown in a larger data set, where he did, again, CT and MRI on a subset of patients who are in Triluminate. And we compared devices versus control. The patients who had devices had decreases in RV and diastolic volume, whereas the controls did not. And the patients who got devices also had improvements in forward stroke volume, where the patients with control did not. And this is a very tight relation that was also correlated to KCCQ in terms of quality of life improvement. And so again, lots of mechanistic explanations as to why patients felt better once they had their TR corrected. So in summary, again, I want to thank you very much for this opportunity to be here. It's really a pleasure. I'd like for you to keep in mind that we're addressing a high-risk neglected condition. Repair and replacement are very effective, and they work and very well in selected patients in our studies. There are new clinical pathways that are rapidly being established. We're learning a lot about how TR could potentially affect survival and quality of life. And when we start having follow-up data beyond a year, we're going to learn even more. This Sunday, Saibal Kar will be presenting the 2-year follow-up of Triluminate at ACC. So if you're there for the late-breaking Sunday morning, I encourage you to tune in. And I also think we're going to learn a lot about the physiology. So I'll stop there, and I'd be delighted to take any questions. And thank you again.
Thank you very much, Paul. Very nicely covered as usual. And for at least the trainees who are looking at the slides, so this is basically how we would learn at Mayo Clinic. And Paul, I'm really excited to see that you've continued the tradition of making sure that every single word is highlighted with the backdrop black and is well spaced out, and the font size and everything. So thank you very
That's
much
right.
for bringing that to the trainees. I mean, I think the primary educational presentation is as big as the content, and I thank you for bringing that to us. I just feel so energized by the whole journey of innovation in the tricuspid space, but at the same time, I wonder whether we have some of the questions that need to be visited. I wonder, first of all, the amount of heterogeneity that we see, not only in the tricuspid valve anatomy, but the response and of the RV and the RA, and how patients develop symptom differently. Yet most of the time, I worry we see many of them coming at very end.
Yeah.
When the heart failure is predominant, and maybe it's a burned out stage. I worry that we are not phenotyping patients more discreetly, or there could be subsets who may benefit from survival.
Yeah.
Have you thought about
Yeah.
how, are there any phenotypes who respond better and may have more survival benefit than the others who are maybe very down at the end of the road and you're not going to see much difference?
I personally think we're just scratching the surface. And you're absolutely right, Partho. We don't have that understanding, because a lot of what we've done so far is we've taken patients who have just TR and assumed that they're all the same. And as a result, we're expecting some of the same results, but it's so different from everything else. So as an example, when we take, for instance, low output, low gradient AS, remember, we used to look at contractile reserve and all these things, and we saw differences in responses, and you can prognosticate patients based on their dobutamine study for AS. Well, TR is actually not too different because we're dealing with dilated chambers and variable responses and heterogeneity, because we don't know if that dilated chamber is elastic or fibrotic or is going to respond to what we do. But what's different right now is that we don't have a dobutamine study for TR. We don't have ways of doing an RV stress test to know that, okay, when I correct this TR, the RV is going to rebound. And that's where people like you and all the imaging world we need help from, because I'm just a plumber. I need an understanding, and I think we all do, as how the RV is supposed to respond. We have things like RVPA coupling and such, but these are singular measures. TAPSE is a singular measure. These are singular measures in space, which we know can change easily if we diurese a patient, if we put them on a GDMT, or we even just give them a salty diet. It doesn't take much. And so because the RV and the TR, they're so the dynamic nature of it is honestly more than any other valve disease we treat. And we need to learn more about that.
Yeah, absolutely, Paul. And that brings me, and I think there's the questions coming up, but I want to definitely visit to you, is when you see this variety of different patients and information coming in, what do you do in a heart team? And how do you converse and how do you extrapolate your knowledge?
Yeah.
Because I would sit and be wondering, I mean, it's a great team, a place for discussion, but how much of time do you have to be able to do that? And in a
Yeah.
fast-paced world where productivity is so important, how do we reconcile with the needs for understanding and a heart team meeting? And what is a heart team? Virtual, in person?
Yeah.
What does it mean to you?
So we have a mandatory heart team meeting every Thursday from 7 to 8:30 a.m. And no patient who is undergoing transcatheter therapy can be treated without being presented there. That's the rule. And the other rule that we have is that the meeting cannot start unless there's a quorum that includes interventionist surgeons in the imagers. So it's a required meeting. And so that's the start of it. But more interesting about it is, I think what you had started to ask about was, how do we decide when and how to treat these patients who have TR? And I'll give you an example about we like I mentioned, we did the first TriClip in 2017 as part of the EFS. And so we've been doing this a long time, but we still have a good way of getting our hands around things. And I'll give you an example. Last week, Nadir Ahmed, my beloved interventional imager, who I think many of you would appreciate as outstanding, said that the RV function is only mildly down. And I said, wait a second, Nadir, the RV is 5.5 centimeters. I mean, once it's dilated, it's not mildly down. You can't have a dilated RV and have mild dysfunction. That doesn't go together. Once it's dilated, it's dysfunctional. And so we had, this back and forth. We just don't understand it, Partho, because she's right in the sense that, well, if it's mild, some of these 5.5 centimeter RVs will come back down to like 4. But how do I know that?
Yeah.
And that's where it's hard.
I completely agree, Paul, because in ASD sometimes you do get dilated RVs, but those recover pretty well. But those are not the same as that we get in tricuspid, but the
Yes.
tricuspid may be so different based upon the chronicity of the disease or
Yes.
geology and so on and so
Yes.
forth. So I just returned back from a vacation and I'm humbled by nature and the evolution of RV. So I went to Galapagos Islands and I realized that some hearts and there are three ventricles, they are three chambered. There is no RV. So I was thinking about do we really understand Harvey and its unique and, functional adaptation to survival? Anyway, but
Yeah.
I'm
I
going
mean,
back.
look at the Fontans, you
Yes,
know?
yes.
I mean, and then the other thing too is, you know, when we first learned about the data, so David Adams and I were in his office and they presented these data to us, and my jaw hit the floor like, oh my God, because I was hoping for a co-op bomb. You know, I think a lot of us were. You know, we wanted to see HFH, death better with triclip, you know, et cetera. But David looked over and he said, this is not a surprise. There's no survival benefit. I said, what do you mean, David? He said, look, we've been cutting out tricuspid valves for decades, you know, in these endocarditis patients, and they do just fine. So you know, you don't need your tricuspid valve. So I was like, wait a second here. So why did you agree to do this trial? So it's there's just so much we have to learn yet.
Yeah, and for Epstein's, for example, some people live for a long time, and you don't need a. I mean, we know that there's a variability on the right side function. Anyway,
Yeah.
I'm going to go back to some of the questions that are there, and Dr. Baganti have a section head for non-invasive cardiology. Thanks you for your fantastic talk. And then, when patients are not candidates for repair or replacement, have you been considering spacers such as Carmes,
Yeah.
etc.? Also, do you identify this patient who might benefit from those? Yeah, I mean the spacer is again a new
Yeah.
concept, but interesting.
Well, it's interesting you bring that up because I did a core maze 2 weeks ago and in France, and I was actually quite impressed. Very easy to do. You know, the controversy about spacers, you know, Cree valve is technically a spacer, it's just a spacer with a valve. The controversy there is that there's nothing holding the annulus. And so the question is any residual leak, what's going to happen to the annulus and the RV over time? We're just going to have to learn, you know, just like I've been humbled by the heterotopic data. You know, trick valve has no effect at the level of the valve, but for some reason, there's been evidence of RV remodeling in these patients in a good way.
And
So there's just so much we don't know.
yeah, and do you think, I mean, I know that the spaces, some of these companies that are coming up, they can be temporarily placed and you can retrieve them back. Maybe
Right.
for a transient remodel. I mean, you don't know RV or how it's going to respond, and then you may be able to be more definitive. I don't know if it's going to be a bailout strategy for the
Yes.
RV.
Yes. Yeah,
Some
no, that's people have talked about that as bridges as well.
bridge, yes.
And bridges, certainly if it's removable, and I think Cora Maze it's not currently removable, but it potentially could be designed that way. And I think those are very real possibilities.
So,
Yes.
one other question, like say Chromase, why is it non-biodegradable or absorbable? Because if you think about how the RV gets larger and larger and larger with right heart failure, a lot of these patients, by the time we see them, have already crossed to the other side.
Yes.
So just wanting to know like what your thought process would be when you pick these patients.
Yeah. So Cora Maze, it's a nitinol frame. It's got a balloon. And so the balloon technically can be pierced so that you could deflate it if you wanted to. But the nitinol frame is needed for anchoring. And honestly, the anchoring has to be solved first because the ability of that Cora Maze device to move would be dangerous for the patient. So you're right. If we had a reversible, biodegradable aspect, that would be very interesting.
Dr. Pantine is our chief of cardiac anesthesia is asking, could MRI be the RV stress test to tell if dilated but with functional myocardium or not, and used as a selection tool? Did prior physical status activity was used as well when randomizing into treatment in the TriClip study?
I do think so. I do think if we understood what the parameters were in terms of stressing, you know, dobutamine study or what have you, I do think that that's something that somebody needs to look at. I don't know of the ability to see scarring with gadolinium on the RV side. Certainly, it's well studied on the LV side, but these are things that we do need to study.
Great. And then I think Dr. Maganti has another question about the use of W stress echo. Have, have you done that to look
No.
at functional response?
I haven't. You know, Partha, I'm sure you remember that Rick did this with dobutamine in the cath lab, and then the people started doing it in the echo lab at Mayo too. But I think it's probably going to be more an invasive approach to look at right atrial pressures, in addition to the functional approach from looking at it from the echo standpoint from the RV. But I honestly, I'm putting this out there because someone needs to do it. We have not done it.
And if people are wondering who is Rick, it's Rick Nishimura.
Oh, Rick Nishimura.
Yeah, so just because a lot of people may not know
Yes.
Rick Nishimura name, or maybe knowing it, but I just wanted to bring out, we're humbled by his hemodynamic teachings in the cath lab and clinical medicine in general. Yeah, Kamu, you were asking another question.
No. We used to do the dobutamine stress testing for all the liver transplant patients. Their RVs were pretty huge, and you could actually show contractile reserve, and they remodeled really well. Those RVs remodeled, but what we are dealing with is completely different. So I don't know. Unless we study it, we might never know.
Yeah, the problem that I feel we have our challenges with the atrial fibrillation coming in between, and the ventricular response with the dobutamine just becomes very difficult to manage. And that's been our problem. AFib, and AFib is a pretty strong company
It's
problem.
90%. 90% of TR has AFib. Yeah, and so I'm not sure how to manage that. Yeah.
Yes, and then I was also interested to understand one more question. The RV responses, particularly for when you're debating if the RV is dysfunctional. Have you had a situation where you put the clip in and the cardiac index just dropped down and you had to put a bailout strategy for
the only time we had trouble was actually just one time, and it turned out that patient had amyloid. And we did a clip, and the patient had terrible RV failure afterwards. And so amyloid is something I think you could pick up on a cardiac MRI. And so, these are things that, again, we need to study a little bit more carefully. But otherwise, even with very dilated RVs, we have not seen issues with TriClip. To give one perspective is that most TTVR technologies target a range of annular perimeter of 120 to 140. VDYNE is exceptional in that it goes up to 175. But the average annular perimeter in TriClip was actually 188. So it was actually at the far end of the tricuspid size. And and despite that, we didn't see issues with TriClip. Now, someone may argue, well, it's because you're leaving some TR behind. That's a very fair statement. We're not capping it off completely. But, we just didn't see it.
See. And Paul, with regards to Evoke, these are massive devices many times. How much do you see deforming of the annulus, and does it have an impact on the left-hand side?
Yeah,
because
it's a good question. And so we actually have seen with Evoke and with TriClip, patients with left-sided mitral disease actually get better. And I think it's because the HFpEF gets better, believe it or not. But the one thing we also have seen with all these replacement technologies is that the TAPSE gets worse. The annular descent isn't the same. The annulus essentially becomes fixed. As to your point, it tends to be splinted. I brought up VDYNE because VDYNE, back in medical school, I always taught that the left side is a donut and the right side is a croissant. So we're when we're taking circular valves, we're making two donuts. Whereas VDYNE, it actually preserves the croissant shape. And and that's the natural state of the RV. And so how that affects the right side and the the right sided function in the future needs to be looked at a little bit more.
Fantastic. Nadira and myself, we are trying to engage in some collaborative work, and we hope to
Yes.
be able to pull you in some of this work if there's an ability for us to answer the big challenge with the right ventricular function and the heterogeneity. So with that, I think we come to the end of the talk, and thank you very much, Paul, for
Yes.
joining us, and we look forward to seeing you at ACC, and hopefully in the next year bring you back in for in-person session.
Thank you all.
Thank you all.
Thank you so much for having me. Okay.
Absolutely. Take
Have a
care.
good night.